Today I will be talking about orthostatic hypotension. It is defined as a decrease in systolic blood pressure of 20 mmHg or more, or diastolic blood pressure of 10 mmHg or more within 3 minutes of standing from supine position or on assuming a head-up position of at least 60 degrees during tilt table testing. It is associated with increase in cardiovascular and all-cause mortality, and it predisposes to falls and cognitive decline. Prevalence of orthostatic hypotension is around 5% in adults who are below 50 years of age, and around 20% in adults older than 65 years of age, and around 25 to 30% in nursing home and long-term care residents. Risk factors such as diabetes increase the prevalence of orthostatic hypotension in all age groups. Pathophysiology. Approximately 500 to 1000 ml of blood pools in the lower extremities and in the splanchnic circulation, causing reduced venous return to the heart and cardiac output, leading to organ hypoperfusion. The normal physiologic response to standing is mediated by baroreceptors, which cause increased sympathetic activity, leading to increased heart rate and contractility, and peripheral systemic vasoconstriction, causing increased venous return to the heart, thereby maintaining the blood pressure. Orthostatic hypotension results from autonomic system failure when the sympathetic mediated vasoconstriction is unable to compensate. Functional classification of orthostatic hypotension. Class 1. Patients are asymptomatic but occasionally show symptoms of orthostatic intolerance with unexplained falls. Class 2. Symptoms occur weekly or monthly with mild to moderate limitations of daily living. Class 3. More severe and frequent symptoms with marked limitation of daily living. Class 4. Severe symptoms that occur daily and leading to recurrent syncopal episodes. Cardiac and extracardiac disorders associated with autonomic dysfunction. Orthostatic hypotension is associated with increased risk for left ventricular hypertrophy, myocardial infarction, atrial fibrillation, and heart failure. It is associated with hypercoagulability, which in turn increases the risk of stroke. It's also associated with increased risk of dementia and syncope. It is associated with chronic kidney disease and chronic obstructive pulmonary disease. There's increased risk of fractures and falls. Clinical phenotypes of orthostatic hypotension. Initial orthostatic hypotension is defined as decrease in systolic blood pressure of 40 mmHg or more, or diastolic blood pressure of 20 mmHg or more within the first 15 to 30 seconds. It is often transient. Classic orthostatic hypotension is defined as decrease in systolic blood pressure of 20 mmHg or more, or diastolic blood pressure of 10 mmHg or more within 3 minutes upon standing. It's the most common form seen. Delayed is defined as drop in blood pressure greater than 20 over 10 mmHg after 3 minutes upon standing. It may represent early and mild autonomic dysfunction. Orthostatic hypotension is further classified as neurogenic or non-neurogenic. Neurogenic orthostatic hypotension is caused by an intrinsic failure of the autonomic nervous system. There is impaired sympathetic activity and impaired vasoconstriction. Non-neurogenic orthostatic hypotension is usually secondary to external factors. There is reduced intravascular volume and cardiac dysfunction. Heart rate compensation ratio, which is change in heart rate to change in systolic blood pressure, is decreased to less than 0.5 beats per minute per 1 mmHg in neurogenic and increased to greater than 0.5 beats per minute per 1 mmHg in non-neurogenic. Symptoms of autonomic failure such as urinary and gastrointestinal dysfunction are seen in neurogenic and not present in non-neurogenic. Causes of neurogenic and non-neurogenic orthostatic hypotension. Neurogenic: spinal cord injury, traumatic brain injury, dementia with Lewy body, Parkinson's disease, peripheral autonomic disorders such as diabetes, amyloidosis, non-neurogenic endocrine causes such as adrenal insufficiency, diabetes, hypothyroidism, iatrogenic causes such as medications, substance abuse from drugs or alcohol, metabolic due to vitamin B12 deficiency, blood loss from trauma, anemia, cardiac causes such as congestive heart failure, myocardial infarction, symptoms of orthostatic hypotension, cardiovascular, chest pain and palpitations, pulmonary, dyspnea, fatigue, gastrointestinal, nausea and vomiting, musculoskeletal, neck and shoulder pain known as coat hanger syndrome, central nervous system, blurred vision, lightheadedness, syncope. Medications that can cause orthostatic hypotension: antihypertensives, centrally acting alpha-2 agonist, negative ionotropic and chronotropic agents such as beta blockers and calcium channel blockers, preload reducers such as nitrates and diuretics, vasodilators such as alpha-1 adrenergic antagonist and direct vasodilators, renin-angiotensin system antagonists such as angiotensin converting enzyme inhibitors and angiotensin receptor blockers, tricyclic antidepressants, anticholinergic agents, opioids. Initial testing for patients with orthostatic hypotension, basic metabolic panel to evaluate for electrolyte disturbances and renal dysfunction, complete blood count to evaluate for anemia, B12 methylmalonic acid level to evaluate for vitamin B12 deficiency, hemoglobin A1C to evaluate for diabetes, TSH and free T4 to evaluate for hypothyroidism, AM cortisol level to evaluate for adrenal insufficiency, EKG to evaluate for cardiac arrhythmia, echocardiogram to evaluate for heart failure, urine drug screen to evaluate for substance abuse. Algorithm for the evaluation and management of orthostatic hypotension. Patients with signs and symptoms concerning for orthostatic hypotension, and if clinically stable and able to perform a standing test safely, perform supine to standing orthostatic vital signs. If the patient is unable to perform standing test, or if the clinical suspicion for orthostatic hypotension is high despite normal orthostatic vital signs, perform head-up tilt-table test. If the standing test or tilt-table test is positive for orthostatic vital signs, classify it into neurogenic versus non-neurogenic based on heart rate compensation ratio, which is less than 0.5 beats per minute per 1 mmHg in neurogenic and greater than 0.5 beats per minute per 1 mmHg in non-neurogenic. In case of non-neurogenic orthostatic hypotension, correct the underlying etiology. In case of neurogenic orthostatic hypotension, evaluate for supine hypertension, which is defined as systolic blood pressure greater than 140 mmHg or diastolic blood pressure greater than 90 mmHg after 5 minutes of supine position. Start with non-pharmacologic management, and if the treatment goals are achieved, continue to monitor. If not, then add first-line medications such as midodrine or droxidopa, and if treatment goals are achieved, continue to monitor. If not, add second-line medications. Postural orthostatic tachycardia syndrome is a distinct entity from orthostatic hypotension. It is defined as symptoms of orthostatic intolerance, which include lightheadedness, dizziness, palpitations, fatigue, and weakness. It's also defined as increase in heart rate of greater than 30 beats per minute within 10 minutes of standing from supine position and absence of orthostatic hypotension. Other clinical features include standing heart rate typically greater than 120 beats per minute. Symptoms occur with upright position and are relieved with supine position. Symptoms worse in the morning, and it is a chronic disease, most prominent between 15 and 25 years of age. Indications and procedure for head-up tilt-table testing. High index of suspicion for orthostatic hypotension despite normal orthostatic vital signs. Inability to tolerate assessment of standing orthostatic vital signs. Assessment for chronic orthostatic intolerance such as postural orthostatic tachycardic syndrome. Patient should have an empty bladder and be secured to tilt table using straps. They should be maintained in a supine position for at least 10 minutes, and the patient is slowly tilted upright to 60 degrees. Continuous non-invasive blood blood pressure and heart rate monitoring is needed for detecting orthostatic hypotension. The test is terminated when the diagnostic criteria is achieved or the patient becomes intolerant. Management of orthostatic hypotension. Treatment should aim at reducing the symptoms and improving the quality of life rather than normalizing the blood pressure. In case of non-neurogenic orthostatic hypotension, one should correct the underlying cause, discontinue the medications that can contribute to orthostatic hypotension. Nighttime dosing of antihypertensive can prevent supine hypertension and reduce the chance of orthostatic hypotension. Pharmacologic management of orthostatic hypotension. Medications can be used to treat orthostatic hypotension if non-pharmacologic interventions have been insufficient to control the symptoms. Two medications that have been FDA approved for the treatment of orthostatic hypotension are midodrine and droxidopa. Midodrine is a short-acting alpha-1 adrenergic agonist which increases the peripheral vascular resistance. It is started at a dose of 2.5 milligrams 3 times per day and titrate up to 10 milligrams 3 times per day. It should be avoided before bedtime to prevent supine hypertension. Major side effects include supine hypertension and urinary retention. Droxidopa, it is a synthetic norepinephrine precursor and it augments sympathetic vascular tone. It is started at a dose of 100 milligrams 3 times per day and titrate up to 600 milligrams 3 times per day. It should be avoided before bedtime to prevent supine hypertension. Side effects include headache, nausea, and supine hypertension. Other medications that have off-label use for the treatment of orthostatic hypotension include fludrocortisone. It is a synthetic mineralocorticoid. It causes sodium and water retention and expands plasma volume. The starting dose is 0.1 milligram per day and titrated up to 0.2 milligram per day. Major side effects include edema, hypokalemia, and heart failure exacerbation. Pyridostigmine, it is a acetylcholinesterase inhibitor. It is given in a dose of 60 milligrams per day. Major side effects include GI upset and muscle cramps. Atomoxetine, it is a norepinephrine reuptake inhibitor. It is given in a dose of 18 milligrams per day. Major side effects include insomnia, supine hypertension.